Good morning. Thank you very much. Those are my financial disclosures. And what is my task? Can we improve screening method of colorectal cancer? And to those of you who are running to parallel sessions, I will say yes, we can. And I'm going to show it to you. So what is the ideal colorectal cancer screening test? It should definitely be on an organizing program nationwide, like Professor Regula was successfully done in Poland. It should have high uptake. The test has to be accurate. The most important is the negative predicted value. I'm not concerned of false positives because anyway, I'm recommend to all my patients to do screening colonoscopy. But I hate to tell someone, yeah, you can go home, but there is cancer. So the negative predicted value is the most important one. Obviously, the quality, the cost, adherence to surveillance. It's meaningless to have an outstanding test which is not adherence. I believe in the bottom line, so reduce the incidence of colorectal neoplasia, a test that can reduce the incidence of colorectal cancer, a test that can reduce specific morbidity, specific mortality, and most important, overall mortality. So there is different screening modalities: blood test, stool test, sigmoidoscopy, colonoscopy, CT colonography, and capsule endoscopy. The best screening test is the one that gets done. So everyone has different visions, different dreams. So as physicians, we have to try to find the right test to the right man. No one likes stool testing, I can tell you. Therefore, I don't believe in stool testing. Blood test is highly desired, but still does not exist. There is some options. I'm also trying to do it in my lab, but we still do not have it. We also have a major problem with colonoscopy. The public votes with his legs against screening colonoscopy. So in 2017, any screening modality is better than nothing. Most probably, colonoscopy is still the best options. I'm going to tell you a secret. This is a study that was done by Professor Regula, and this was the first landmark study that was done 11 years ago, showing that it is feasible and doable. So this is a secret. My wife is perfect. I thought that I'm perfect. She doesn't think so. Most probably she's right. But there is no doubt that colonoscopy is definitely not perfect. So, and we do miss adenomas, maybe not these ones, but we do miss adenomas, and we do from the literature that we do miss adenomas in about 20% of the cases. So this is one of the coined that Professor Regula, one of the parameters that was first coined to describe the quality of endoscopy was the adenomas detection rate, ADR. As we can see it here, high ADR, those here, there was almost no interval cancers as compared to the rest. So if one had an ADR of 20%, these patients most probably are not going to have any interval cancer. And this is another way how to look on the details, on the data. High ADR decreases the risk of colorectal cancer deaths, as you can see it here. It is amazing. For each 1% increase in ADR, there is a 5% decrease in colorectal cancer deaths. And this is what we're doing now as gastroenterologists, was just the president of the Israeli Society. We're trying to educate our gastroenterologists. And just if we are able to increase it by 1% the ADR, it has really meaningful. So why do we miss adenomas? Like we heard, it's inadequate colonic preparations, flat and depressed lesions, colonic anatomy, especially behind folds, suboptimal techniques, short withdrawal time, missing second intubations, which results in low ADR, and current technology limitations. So again, a paper coming from the group of Regula, which coined what are the quality indicators for colonoscopy. And again, I'm jumping to the end of my talk. I think this is the most important issue, to have a good colonoscopy. So these are what are the quality of colonoscopy: good preparations. Second, should be intubated and documented by photography. Colonoscopists should measure their ADR. It's not an easy task. It's not easy to obtain, but they should have it for 20%, at least for women, 30% for men, and withdrawn time in negative colonoscopy should be 6 minutes. So how can we improve polyp detections? We can use extra wide angle view, better view, full spectrum endoscopy, third eye rotoscope, aeroscope, GI, endocuff, endorig, colonic capsules, and prepless colonoscopy. So I'm going to show you all these exciting new innovations. So first, it makes sense to try to mechanically flatten the mucosa. So this is just a cup. As he said, you mount at the tip of the scope a cup, which helps to flat the mucosa, and you can see that the endpoint is polyp detections. It was slightly higher. Number needed to treat with 13s, and I'm going to show a sample. You can see this is a colonoscope. There is no polyps, cannot be behind folds because there are no folds. So there obviously should be a better way to look on the data. Another one, it's a pentacolonoscope with permanently integrated reusable balloon. The balloon inflated through the colonoscope internally. You can see it here, so you can control it whenever you wish. Usually you do it when you reach the cecums. Balloon inflated to engage the colonic wall during the withdrawal. We can see it here. You can see on the left when the balloon is deflated, and this is balloon inflated. So you see those are folds here, almost no folds here. So it should help us better to see better. And again, there were some studies, results showing that positive results. This is the endocuff. You see this is coming from inside the scope. You have this teeth that when you pull back the colonoscope, you are able to see behind folds. This was another study showing that the ADR was significantly increased by 86% when you use the cuff as compressed when you did not use it. It was published in GI endoscopy. Endoring, the beauty of simplicity, you just attach this plastic, very flexible at the end of the scopes, and I'm going to show you that you can see this polyp that if you would not use the endoring, you are going to miss it. And let's see it here. So this is a scope. It's very flexible, so it does not disturb in the maneuverability of the scopes, and only by this way you are able to see this polyp that otherwise would have been missed. I will tell you a secret. I used it. It's nice to have when you're doing studies, but on a busy day when you have to do 15, 20 colonoscopies, it's less of a fun, and it's like to be, and this is what I come to be one of the problems of this technique. So this is endoring. This is a clever study, again showing the superiority. The study endpoint was adenoma miss rate, 15% with the endoring, 48% without the ring. What else can we do? This is the optical approach. We can see better. So there is the third eye, fuse, full spectrum, and the omnivisions. But first, this is Olympus. They have the extra wide angle view endoscope, and you can appreciate it here. This is a cecum, excellent preparation, but also very large view of angle 190 degrees. Definitely can help us. This is a fuse. As you can see, it has 3 screens. This is a forward view. As you see, the right lateral and left lateral. So actually, we are becoming like Paulus. I have to see on 3 different screens. Actually, the story is very interesting. It started at the north part of Israel in a small village at the kitchen. And you can see it with the first model of the colonic models, ex vivo. It was taken from the laundry machine. And this is the animal lab with the 3 screen with Professor Ori Segol, who helped me to give me these slides. And here we can see the data. So this is the forward view. This is the right lateral and left lateral. So look on this polyp that you can see on the left. You don't see it on the forward view, definitely not on the right view. So this small polyp was only able to see when using with 3 screens. This paper was published in Lancet Oncology by Ian Guralnik, and look, amazing results. So in this study, what they have done, first you go inside with a forward view, followed by the fuse, or the other way around, first with the fuse and then for the standard follow scope. And you can see the additional adenomas detected when you do coming first with the standard colonoscope followed by the fuse was 69%. 69% adenomas were missed as compared to 8%. Adenoma miss rates of 40% versus 8%. However, the ADR were almost the same. So the few study was very fascinating. However, follow-up study that came from Italy by Cesare Hassan, multi-center study, and the result was not that great. And ladies and gentlemen, as we know, there is a big gap between medicine, science, and economics. Fuse was bought by Boston Scientific, was a big hurrah on the media. However, after 3 months, the project was abandoned. We still do not know what exactly caused Boston Scientific to buy an endoscopy, because it's not on their target, because they don't sell endoscopies, and that might be the end. After 3 months, the end. This is another device that has 5 cameras. It came to the market in late last year. We still do not know the data. What about the third eyes? This is a device that passes through the scope channel. It automatically retroflects in 180 degrees. It provides both forward view and backwards view simultaneously on side-by-side monitor. This is a paper that was published in GI Endoscopy, again showing its superiority. However, I spoke with Jerome Way, was one of the principal investigators of this study. He's a godfather of endoscopies from Mount Sinai in New York. And he told me, this device is not a friendly users, because you're using the same channel to use the third eye. If you find a polyp, you take it out, and then you have to put the polypectomy. You have to do the polypectomy. So, and there is nothing more frustrating when you saw a polyp and then you cannot find it anymore. So it was very time-consuming. It was increased the procedure's time and cost, and it did not catch up. This might be better, third eye panoramic. It's the same colonoscope. We still have the working channels, but it's a device that is attached to the colonoscope. It has a forward camera, right-sided lead, left-sided lead. There was one study published in World Journal of Gastroenterology, did not catch up. The aeroscope, I presented it first about a decade ago. Here we had a cover page in Gastroenterology. It's technology taken from the Israeli army, omnidirectional 360-degree visions, joystick controlled for self-propelled colonoscopes. Scanner induces very low pressures on colonic wall, so it's very safe. It is disposable, single operator, and it is the only available FDA-approved self-propelled colonoscope. You can see it here, how it works. A decade ago, I thought it's going to change the natural history of colorectal cancer. I think we missed the point. I'm now less involved in this, but as you can see, there is very impressive technology. So you see, it's very easy to mount. It's very flexible, very soft. It has suctions, irrigations. It can, anyway, they have the joystick to control. And now we are going to see how we do it. So we also have 2 working channels to do polypectomies, to take biopsies. You insert the tube into the colon, then you inflate the rectal balloon to anchor the device to the colon, and you just push it. Usually, because it's so flexible, it can reach the splenic flexure, and then you inflate the back balloons and then increase the pressure behind the balloon. You push the balloon from the rectum to the cecum by himself. It's self-propelled. When it reaches the cecum, you deflate the pressures in front of the balloon, you inflate it then, and then you do the screening using the OmniVision, which is entitled to have 360 view. You can see this is this is real life. This is the forward view, and this is the OmniVisions. And as you can see it here, forward view, you are going to miss these polyps. I will show it again. This polyp is going to miss by the forward view, but this you can see by both forward and Omni, but this one only by the OmniVisions. When the device reaches the rectum, the rectal balloon is deflated, and the OmniVision, you are able to screen the rectum. So this was the aeroscope. It did not catch up still, and there are still many more studies to do, and especially now when the ADR is so high, I think they have missed the point. Motos GI is started in Boris' house in Nazareth as a self-propelled single-use colonoscope. It was first found in an Arab-Israeli incubator, but it changed directly into an add-on device that cleans the colon during colonoscopy. We can see it here. It's called now. This is a device. It has a very strong irrigations and a very strong suctions. And we can see it here in real life. You see that the strong irrigations, you're able to completely clean. Here you see the endoscopy doing it. You can completely clean the colon. I presented a couple of years ago something similar. It's called the Clear Path. We even published it in endoscopy. This was the first time that I was able to do prepless screening colonoscopy. Patient came to me from work, did not have any preparations, and we did about 11 patients. It was a lot of satisfactions because of doing as a study to publish it. But I don't think this is what my mother wanted when she wished me to have a distinguished job. So I think what we have the boundaries of the physicians. Physicians say, we are not willing to take the task of the patient. So it did not work up and it didn't catch up, and this technology was abandoned. Capsule endoscopy. This is also coming from Israel. You can see it here, one of the first one of GI view, then Medtronics. And here you can see the small bowel, and soon we are going to see some polyp or cancer. You can see it here. This is a small bowel. You can see the villi. Then when we enter the cecum, there is a lesion here that is most probably cancer, and this is a transverse colon. You can see this triangle, and again, we are going to see a lesion. There is a lot of pros and cons for capsule endoscopy. I think it's amazing technology, maybe for the small bowel, but the small bowel doesn't have so many diseases, but the colon is too complicated, the preparation is too complicated, it's too difficult. This is the ESG guidance, the FDA guidelines, so actually it should be done only in patients with incomplete colonoscopy or when colonoscopy is contraindicated. It's also a good option to have an expensive selfie. One of our patients, and this is a courtesy of Rami Eliakim, he went to the loo and he saw something is flashing. He looks at it and then he has his selfie. This might be another amazing. This is a prepless capsule colonoscopy, ultra-low dose X-ray based imaging technology. It's patients, doesn't have to make any preparations. They come to the clinic, they swallow the capsule, like the capsule is given, continue with their daily life. This is a capsule scan. It's used very low dose of energy. Everything is done by the physicians in the office. You can have the 3D reconstructions of the colon, very good map of the colon. We have done a few hundred cases, but still it's far to be done on a routine basis. But if we can overcome the preparation, that might be a good option. I showed you some success, some things that we are on the way, but there were some failures. We always have to remember it. Inventoscope failed, it's from Germany. Protectiscope came from Israel when it's bought by Stryker, but the end of it. I showed you about ClearPass also. It was withdrawn from the market. So there is some success, there is a lot of failure. We can also improve the imaging. We can increase magnification. This is standard scope, high definition, threefold increase. We can have 300 zoom magnifying colonoscope and even confocal high microscopy. Again, in studies it's nice, real life doesn't really help. Optic imaging. It is interesting that the behavior of visible ultraviolet and infrared light emitted from a source to a surface is variable. Light may interact with tissue in various ways that can be measured and analyzed. Reflections, absorption, single scatters, multiple scatters, fluorescence. So there is a number of technology like chromo endoscopy, and we can do it by ourselves, NBI, FIS, eye scan, endoflags. Good results in clinical studies. This is chromoendoscopy when you do it by ourselves. In real world, it doesn't work. This is electronic chromoendoscopy. I'm using NBI, eye scan. Again, no real added value. Again, some examples to see it. The future, and this is what I think is going to happen, is molecular imaging. I just give you some example from my lab. We developed monoclonal antibody to CD24, and when we inject it IP to mice, and this is a tumor, you see that after some times the antibody is concentrated in the tumors. It could be in the future help for diagnosis or also for therapy. Also for the capsules, if you can put like enema with this kind of antibodies, we are able to see when the capsules comes, it can detect exactly because it will be able to detect these antibodies. Ladies and gentlemen, jumping into conclusions. A test is better than none, and the best test is the one that is done. There is a two-stages approach. Non-invasive tests are the initial step: blood test, stool test, virtual colonoscopy, capsules, preface colonoscopy. In the future, it is going to be, but currently, I would strongly recommend for the one-stage colonoscopy. Let's do the right test. And I agree with Professor Regula. We need the big brother to watch us doing our job meticulously, and there is nothing like having a good colonoscopy with ADR, withdrawal time, second intubation rate. Very advanced technologies are available, but they are still time and money consuming. And the best things, so no matter how advanced the technology and equipment are, what really matters is the gastroenterologist. Thank you very much, ladies and gentlemen, for your attention.